Really, the Revisit US study is two separate studies. One looking at rivaroxaban in comparison to a vitamin K antagonist in patients with non-valvular atrial fibrillation, and the other is looking at apixaban compared to vitamin K antagonist, in this case warfarin, again, on patients with non-valvular atrial fibrillation. In this case, we used a large claims database. And this large claims database was called MarketScan, which is a very commonly used database for these types of studies. The goal of this research was to determine whether or not both of these agents, these novel oral anticoagulants, whether we were seeing the same results or similar results or consistent results as we were seeing in their clinical trials. So comparing rivaroxaban again to warfarin would be, we want to see whether it was consistent with the results of ROCKET-AF, whether apixaban and warfarin had similar results as what was seen in the Aristotle trial. This is looking at large claims data, so looking at a real world picture of how this is. And that's important because often clinical trials give you a very internally valid assessment of how drugs work, but when they hit the real world, people use them in different ways than you would expect or based on what was done in the clinical trials. And so you really want to know how it works in the real world. So we found a couple of interesting things. So the first thing is with the rivaroxaban portion of the study is that the results we saw in our Revisit US study were very consistent with those seen in ROCKET-AF. And basically what that was is there was a trend towards a reduction in ischemic stroke, although that did not reach statistical significance. However, there was also a statistically significant reduction in the risk of intracranial hemorrhage, which is really one of the benefits of all the novel oral anticoagulant agents. Again, and these results were very consistent with those seen in the phase 3 clinical trial ROCKET-AF. Well, what it means for patient care is one, clinicians and patients can certainly feel more comfortable about the fact that the drugs behave the same in the real world as they do than they did in the randomized controlled trials. Because, again, patients take drugs in different ways, clinicians prescribe them in different ways, and we want to make sure that, the patients are getting the benefits that we expect and they're not getting any more harm than we anticipated in the trials. I think when we're talking about agents, again, like rivaroxaban, the key is trying to demonstrate where the real benefits are. And so again, the real benefit of novel anticoagulants, including rivaroxaban, is that ability to prevent or to reduce your risk of intracranial hemorrhage. So those bleeds that are really associated with a lot of morbidity and mortality. At the same time, you're getting at least the same efficacy in terms of preventing stroke, which is really why we're giving the agent. The second part of the study actually was, again, looking at apixaban versus warfarin. And there we actually found some very interesting results. And so again, as we'd expect with all the NOACs, we were showing a reduction in intracranial hemorrhage. However, there's starting to appear that there seems to be a trend towards an increased risk of stroke with apixaban as compared to warfarin. And the exact reason for this is difficult to understand because of claims data, but there's certainly some reasonable hypotheses. And some of those hypotheses might include poor adherence with a twice daily novel oral anticoagulant like apixaban, or also underdosing. And so in my own personal clinical practice setting, we often see patients receiving lower doses of apixaban than we often, or that you would expect to see based upon what was studied in the clinical trials or what's suggested in the prescribing information. I believe the reason behind that is that clinicians are really afraid of major bleeding. And this is not just true with NOACs. This is something we've been seeing for years and years with warfarin. So, and even when we were giving patients warfarin and we were looking at INRs, you would always see a tendency for clinicians to aim for the lower end of the target range, or even being willing to tolerate INRs that are slightly below that target range. And when we used to talk about with warfarin that only about 50% of the time patients spent in that target therapeutic range, INR range of 2 to 3, if you looked at the time that they were out of range, it was almost a very large majority of the out of range time was below the therapeutic range and not above, which just goes to show that we're very risk adverse as clinicians. And I can to a certain degree understand that. We don't want to do harm to our patients. But what we do need to remember is that having a stroke is probably going to be worse in terms of a patient, in terms of doing harm, because it's associated with a lot of mortality as well as morbidity, as compared to some of the major bleeds, such as gastrointestinal bleeds that we see with novel agents, which I'm certainly not I don't want to say are irrelevant, but they're certainly not associated with the same amount of morbidity and mortality. I think to a certain extent the message, again, is the same. And again, particularly for the rivaroxaban data, is that consistency, that we're showing the same types of results in real-world evidence as we showed in the randomized controlled trials. And so we can feel reassured of it. Now, to a certain extent, there is more underprescribing or using lower doses of novel anticoagulants in Europe and other areas as compared to US. It's also a problem in the US, but from the data I've seen, it's probably even a little more of a problem in Europe. So to a certain extent, it's important for them to see this type of literature as well. There's a lot of things as pharmacists that we're trained to understand about drugs, that we need to make sure that we impart to our other clinician colleagues. So there's often, when we talk about novel oral anticoagulants, there's a lot of misconceptions about things like half-life and duration of action. People ask questions such as, why can one drug be a once daily drug and another NOAC be a twice daily drug, even though they have the same half-life? And it comes down to the fact that they have, things like duration of action, pharmacokinetics, drug interactions. These are all things that clinicians have questions on. And, they have some information that they get from the prescribing information or the package insert, but they don't have a great deal of detailed information. And sometimes, it's very helpful to have a pharmacist come in and really explain the true impact or importance of these things, such as a half-life of a drug, the duration of action, CYP3A4 interactions, things like that, which I think sometimes we'd all like to just stick our heads in the sand and forget. This is, again, kind of a first look at the data. And so hopefully what we would like to do is, as more and more patients start to receive these novel oral anticoagulants, is to refresh the data and to be able to look at it over time to see if these results remain the same. So right now, again, I think the key points are, look, the NOACs in general are resulting in decreased intracranial hemorrhage, and that's a good thing. And that, particularly with rivaroxaban, we're able to show that the results are consistent with what we saw in ROCKET-AF, and that should provide some confidence to clinicians and some confidence to patients that by not using warfarin and going to a drug like rivaroxaban, that they're doing a good thing for themselves, that it's going to result in good outcomes.